A very good evening to all of you. Myself, Dr. Prateek here. So today we will discuss about tuning for test. Very important for the examination point of view and very useful in clinical setup. So firstly, we need to understand about impedance matching mechanism. What is this? See what happened. The sound energy is coming from the air. Then it enters into the external ear, goes into the middle ear, and then through the middle ear it enters into the inner ear, and we all know this inner ear is filled with the fluid or with the water. So the sound energy from air is traveling into the liquid medium, and because of that 0.1% only the 0.1% of the sound energy is going inside the inner ear because of all this impedance. So there is a system in our body by means of external ear or by means of middle ear ossicles or the tympanic membrane, by which the sound energy which we are perceiving get amplified, get magnitude got increased, the force get increased to match that impedance or the resistance which is being produced because of change of medium from air to liquid. I hope you got it. So there is a mechanism to match that impedance or to overcome or to just feedback, or we can say to compensate that impedance because of the inner ear fluid. So there is a mechanism which is known as impedance matching mechanism. So how it happens? See, there is a tympanic membrane. We all know it is a round structure which is around 9 to 10 mm tall and also in the width. So the effective vibratory area of the tympanic membrane is considered 45 mm to 45 to 55 mm square. More correct is 55 mm square. So the tympanic membrane effective vibratory area, that means the central part of tympanic membrane is attached to the malleus handle, whereas the peripheral part is little bit free. So peripheral rim of or the peripheral part of the tympanic membrane is more mobile as compared to central part. So the effective vibratory area comes out to be around 55 mm square. Whereas if we compare with the area of the stapes footplate, which is around 3.2 mm square. 3.2 mm square. So you know difference. See, the bigger tympanic membrane vibration, the bigger surface area is converting or converging the sound energy to a smaller area of the footplate, that is 3.2 mm square. So bigger area, from the bigger area sound is going towards a smaller area. That is one mechanism. Then comes the next mechanism, which is the lever ratio. What do you mean by lever ratio? The handle of malleus as compared to long process of incus, there is a difference in the length, or we can say area, of around 1.3 times. That is, handle of malleus is 1.3 times longer than long process of incus. So that will give an additional benefit, or the lever ratio of 1.3:1. Whereas this tympanic membrane surface area as compared to stapes footplate area will give an additional benefit which is known as aerial ratio of around 14:1, or we can say 17:1 by considering the 45 mm or 55 mm square. More correct is again 17:1. So the aerial ratio or the additional benefit, because of the difference in surface area, we got an additional benefit of 17 times. Whereas because of the lever ratio, we get an additional benefit of 1.3 times. So if we combine this ratio, or we can say the transformer action, so we get an additional benefit of around either 18:1 or 22:1 by 18:1 or 22:1 because of the difference of this. So we get this ratio. So what do you mean by transformer action or transformer ratio? See, this middle ear will amplify the sound energy to compensate for the loss. So it will convert this sound of low force, or we can say low pressure, into the sound energy of high pressure or high force, so that it can easily travel into the inner ear and can compensate for the impedance offered by the inner ear. This is known as transformer mechanism or transformer action of the middle ear, where the sound energy of the low force or low pressure is converted into the sound energy of high pressure or high force by means of the surface area difference and by means of the lever ratio. So additional benefit we get is around 18:1 or 22:1. More correct is 22:1. Okay, so there was a scientist Becky which got a Nobel Prize in the 2008 for this traveling wave theory, which is the most acceptable theory for the sound wave transmission and perception and everything. Now, there are three types of hearing loss. The first one is a conductive hearing loss, where the disease will interrupt with the mobility of tympanic membrane or the mobility of bones. So, conductive hearing loss basically involving the external ear and the middle ear. Any pathology in external ear or middle ear will lead to conductive hearing loss. Then comes a sensory neural. So, sensory means the cochlea, neural means the eighth cranial nerve. So sensory neural hearing loss basically are because of the lesions or pathology of cochlea or the auditory nerve or the central connections. Then comes the mixed hearing loss, where there is a conductive as well as sensory neural hearing loss. Now, how does this tuning fork work? See, we know the tuning fork shape, we have seen in the OPD. So we put this vibrating tuning fork either in front of the external auditory canal or over the mastoid or over the vertex. There are different tests. So 512, that is a 512 Hertz frequency tuning fork is most preferred one, because if we use the tuning fork of lower frequency, that will produce a sense of bone vibration only. If we use the higher frequency tuning fork, so it will be a shorter decay time. So not very routinely preferred. So this is 500 tuning fork, 500 Hertz tuning fork is considered the best. Now let's talk about first hearing test or first tuning fork test, that is Rennie's test. So what is the principle behind Rennie's test? See, we all know air conduction is normally more louder as compared to bone conduction. And why air conduction is better or louder than bone conduction? Because of that impedance matching mechanism present in the middle ear. We have recently discussed. So because of that, if sound energy is being traveled through the middle ear, so it will get magnified or amplitude will get increased by increased force. So always air conduction is greater or louder than bone conduction. So what happens in Rennie's test, we put a vibrating tuning fork in front of the external auditory canal and then over the mastoid. So normally air conduction, when we put the tuning fork in front of the external auditory canal, patient will hear more louder as compared to the tuning fork sound when we put it over the mastoid, that is denoting the bone conduction. So the positive Rennie's test is either suggestive of normal hearing loss, normal hearing, or the sensory neural hearing loss. Why sensory neural? Because in sensory neural hearing loss, the bone conduction will be diminished. Whereas air conduction, because of the magnified amplitude provided by the middle ear impedance mechanism, impedance matching mechanism, so air conduction will be louder. So positive Rennie's test will be suggestive of either normal hearing or sensory neural hearing loss. If Rennie's test come out to be negative, that means if patient says this bone conduction is louder as compared to the air conduction, that means the sound when the tuning fork is put over the mastoid bone is louder as compared to the sound when the tuning fork is kept in front of the external auditory canal. So that means bone conduction, if patient says, is louder and longer as compared to air conduction, that will be suggestive of conductive hearing loss, or we can say conductive deafness. I hope it is very clear. There is no doubt. There is one term which is known as false negative Rennie's test. So when Rennie's test is falsely negative, suppose patient is having only unilateral, that is one-sided sensory neural hearing loss. So in that case, the Rennie's test will be falsely negative. Why it happens? Because if you put the vibrating tuning fork over the mastoid, since this is dead ear, or we can say sensory hearing loss is there, but since the bone conduction may go through the other ear, so patient will hear better because of other ear also. So we can get a false result. So patient will say that bone conduction, the sound is better because of the other ear hearing also. So in unilateral sensory neural hearing loss, the patient may have false negative Rennie's test. Second test is Weber's test. How we do it? We put a vibrating tuning fork and kept it over either the middle of the forehead or over the vertex, and we will ask the patient which ear he is hearing better or louder. Okay, so we will put the vibrating tuning fork either in the middle of the forehead or over the vertex. Remember, Weber's test is a test only for the bone conduction sound. Since we are not using the tuning fork, we are not putting the tuning fork in front of the external auditory canal, we are not using the middle ear system, we are only using the vibrations of the bone suggesting towards bone conduction. So Weber's test is a test for measurement of bone conduction, and when we put the vibrating tuning fork over the forehead or the vertex, and we will ask the patient which ear he will hear better. Normal patient hearing will be same in both the ears, but suppose if patient is having conductive hearing loss, so what will patient say? Patient, because of the conductive hearing loss, so the patient will say, suppose this is my disease ear and I do the Weber's test, so patient will say this ear, disease ear, he sounds better. Disease ear he is perceiving sound better. Why? Because Weber's test, the bone conduction is only being tested, no air conduction is being tested. So if we put the vibrating tuning fork here, so because of the conductive hearing loss, suppose in this ear, the ambient noise or the noise produced by the environment will be absent. So patient can hear the bone conduction sound more precisely because of loss of the ambient noise that happens because there is a conductive hearing loss. So in conductive deafness, the Weber's test will be lateralized towards same side or the worst ear side, whereas if patient is having sensorineural hearing loss, then Weber's test will be lateralized towards the better ear or the ear where there is no sensorineural hearing loss or which is hearing better. So bone conduction will be better if there is no sensorineural hearing loss. I hope you got it. And what is the specification of Weber's test? It can even detect 5 decibel loss. So it is more precise, more specific as compared to Rennie's test. Now there comes the absolute bone conduction test. In this test, what we do, we put the vibrating tuning fork just over the mastoid of different ears, like on the left or the right. In this, how we compare? We compare the hearing threshold of the examiner considering the hearing of the examiner as normal. So what we'll do, we will use the vibrating tuning fork and we put over the mastoid bone of the patient, and if patient says that I can't hear no more sound, then examiner what will do, that will kept same vibrating tuning fork over his mastoid or over his mastoid bone. If the examiner can hear the sound after refusal of the patient, that means patient is having some bone conduction loss in the same ear. If the vibrating tuning fork sound, that means if the patient says that no sound is audible now at a certain time, so if the examiner also in the same time examiner can't hear the sound energy, that means the bone conduction level of the patient and examiner are at the same level, so considering the patient also the normal bone conduction. Okay, so in absolute bone conduction test, patient bone conduction is compared with the examiner, presuming that examiner has normal hearing. So how we do it? We generally occlude the external auditory meatus by either pressing the tragus or by some other means. So why we do it? So if we close this external auditory meatus, so ambient noise which may occur through the air conduction route, that will get occluded. So because in absolute bone conduction test we have to only test for the bone conduction, so air conduction pathway should be closed, and then we will put the vibrating tuning fork over the mastoid to check for the bone conduction. Now what happened? What is the interpretation? In conductive deafness, the patient and examiner, they both hear for the same duration of the time, because we have already occluded the air conduction, also there will be no difference in the conductive deafness because we are comparing only the bone conduction. But if suppose patient is having sensorineural hearing loss, so patient will have decreased bone conduction as compared to the examiner, so patient will hear the tuning fork for a shorter duration. The fourth one is schwabo test. So again, this is same as compared to the absolute bone conduction test. Only difference is the external auditory canal is not occluded in this test. Then comes the Bing test. So what happens in Bing test? What we do in Bing test, we generally occlude the tragus by pressing the tragus and then open it. So we repeatedly closes that external auditory canal, then open it, then closes the external auditory canal and open it, and we'll put the vibrating tuning fork over the mastoid. So we had to check if there is any difference in perception of sound by changing the tragus pressure or by repeatedly occlusing and opening the external auditory canal. So what happens? So in normal person or the person with a sensorineural hearing loss generally hear louder sound where ear canal is occluded. So if suppose there is no conductive hearing loss, only the sensorineural hearing loss, or patient is having the normal hearing. So if we occlude this or do not occlude this, there will be no difference because there will be a difference. If we occlude this, so that ambient noise will get occluded. So patient will perceive better hearing by means of bone conduction. So normal person or the person with the sensorineural hearing loss, whenever we occlude this tragus by occluding the ambient noise, patient will hear better. And suppose better, and if this open up this external auditory canal, we open up and allow the ambient noise to go inside, so patient will hear little bit softer or little bit less louder. So that is considered being positive test. There is last test, Gillies test, very important. Recent year it has been asked multiple times. Gillies test, firstly try to remember, this is a test for the otosclerosis. How we do it? We generally use the Siegel speculum or some other modes to change pressure in the ear canal by means either of the pushing the tragus or opening it, or by means of the Siegel speculum we can give the pressure and then release the pressure. So what happens? Whenever there is a change in pressure in the ear canal, the sound change will also be there if there is intact ossicular chain, because if you change the pressure in the ear canal, if there is continued or ossicular chain, intact ossicular chain, so these pressure will get transmitted to the inner ear. So patient will have a difference in the sound if there is a difference in the pressure. But suppose there is ossicular chain fixation or discontinuity also. So if there is ossicular chain fixation, you put the pressure, release the pressure. Because the fixed ossicular chain or the stapes bone is fixed, so there will be no transfer of pressure changes into the inner ear, so there will be no difference. So it is a test through which we can get an idea